Hi everybody, this is Dr. Ihab Abdurrahman Ihab Tarawa, consultant of acute care medicine at Saba University Hospital, professor of medicine, University of Khartoum. This is a basic emergency care course. In this session we are going to discuss altered mental status. Objective of this session about altered mental status: to perform secondary survey by sample history and secondary examination to recognize key history findings suggestive of different causes of altered mental status. List high-risk causes of altered mental status. Describe critical action to manage patient with altered mental status. Consider disposition and transfer of patient with altered mental status when you are not capable to manage in your facility. Severe hypoxia can lead to altered mental status ranging from irritability, confusion. Patient can have underlying cardiac or respiratory illness. They are having shortness of breath and oxygen saturation is low. Rapidly reversible causes of altered mental status: severe dehydration, hypo and hypoperfusion. You see fluid deficit due to poor intake or due to vomiting, diarrhea or excessive urination, plus those with severe burn, and also patient with blood loss, hematemesis, melena, vaginal bleeding or trauma. You see tachycardia, tachypnea, sweating, low blood pressure, abnormal skin pinch and dry mucous membrane. When we address a patient with altered mental status, after we do the ABCD approach, first we would like to think about rapidly reversible condition, and then we need to look systematically on other causes like infection, metabolic, and other causes. Think always about hypoglycemia after you address hypoxia and hypoperfusion. Patient could be diabetic, could have severe infection or illness, and those with prolonged starvation. This patient with diabetic, when they are hypoglycemic, they get sweaty, they become tachycardic, tachypneic, and sometimes they develop convulsion, and the blood sugar is low when you check with the lab or glucometer. Altered mental status, rapidly reversible causes: heat stroke. You will see exposure to prolonged heat and sun exposure, high body temperature, very warm skin, patient may or may not be sweating. Infectious causes of altered mental status: think about malaria. Patient will present with fever, sweating, intermittent fever, and blood test for malaria will be positive, and some people are from endemic area of malaria. CNS infection can lead to altered mental status like meningitis, encephalitis, brain abscess. Patient can present with fever, neck stiffness, skin rash, sensitivity to light, headache, non-infectious epidemic as in meningitis, and some people are vulnerable like HIV and TB patient. Sepsis is a well-known cause of altered mental status. Patient can present with fever, tachycardia, tachypnea, and they can have hypotension. Plus, you can find sign of infection pointing to specific source like skin infection, lung infection, urinary infection, intra-abdominal or joint infection. Rabies can present with altered mental status. Patient will show agitation, fear of drinking, hydrophobia, drooling, weakness, and history of animal bite. Diabetic ketoacidosis can present with altered mental status due to many factors. One of them is hypoperfusion or severe acidosis or concomitant infection, or when diabetes is a risk factor for intracranial process like cerebral bleed or ischemia. Patient present with history of diabetes, have acidotic breathing, frequent urination, sweet smelling of his breath, high blood glucose, and dehydration. Toxic causes of altered mental status: think about alcohol or drug intoxication or withdrawal. Non-use of alcohol or drug injection. In alcohol, for acute intoxication, patient is drunk, while in withdrawal they have convulsion, confusion, tachycardia. Those with chronic alcohol use, they have balance abnormality, confusion and tachycardia. Opioid, when it is acute intoxication, it leads to lethargy, small pupils, and slow breathing, bradypnea. During withdrawal, patient is agitated, sweaty, having diarrhea and vomiting. Other drug may cause large pupil, agitation, sweating, or fever. Toxic exposure, as in pesticide poisoning. History of exposure: very small pupil, diarrhea, vomiting, and diaphoresis. Snake bite, there will be history of bite. You can see edema, blistering of skin, bruises, hypertension, paralysis, seizure, and bleeding from the wound. Toxic causes in medication reaction or overdose. There could be history of use of new medication or change in the dose. Gaseous poisoning, history consistent with possible exposure, and multiple people are affected at the same time, and some of them have headache. Other causes of altered mental status: convulsion and seizure. There could be a history of seizure. Patient can present actively convulsing or post-ictal and show manifestation like bitten tongue, urinated on himself. Usually they improve gradually in minutes and hours. When seizure happen in pregnant lady with high blood pressure, consider eclampsia. Increasing intracranial pressure can present with altered mental status, as in patient with tumor, trauma, stroke, or brain swelling. They present with headache, convulsion, nausea, vomiting, unequal pupil, weakness in one side, and speech problem. Other causes of altered mental status: liver disease and kidney disease. In liver disease, could be history of alcoholism or hepatitis and cirrhosis. They will present with distended abdomen due to ascites and thin limb. They can have jaundice due to discoloration of the sclera, and some of them they have hypoglycemia. Kidney disease, they can have risk factors like diabetes, hypertension. They can present with edema in legs and even generalized body edema and decreased urine output. Trauma can present with altered mental status. There could be history of recent trauma, scalp laceration and scalp deformity, bruising to the head, blood or clear fluid coming from the nose or ear, unequal pupil, visual changes, loss of memory, vomiting, headache, weakness in one side of the body, and convulsion. Management of patient with altered mental status: when there is hypoxia, give oxygen and treat the underlying cause. When there is hypoperfusion, give IV fluid and treat the underlying cause. Patient with hypoglycemia, you give glucose. If they are conscious and they can take orally, you can do that. Otherwise, you have to give IV glucose. Don't forget hyperglycemia and diabetic ketoacidosis. They need aggressive fluid hydration plus to address electrolyte, insulin therapy, and concomitant infection. Those with sepsis, you need to hydrate well with fluid and treat with antibiotic. In endemic area of malaria, or there is a risk for malaria, you need to test and treat accordingly. When there is exposure to poison like fever and paracetamol, when there is a severe exposure to temperature, you have to give fluid resuscitation. Patient with raised intracranial pressure due to bleeding, start with oxygenation and perfusion, and when there is no trauma, you can elevate the head of the bed at 30 degrees. Don't forget to stabilize cervical spine, and always try to prevent secondary injury due to hypoxia, hypoperfusion, fever, electrolyte abnormalities. Suspected hypothermia: move to warm environment, remove wet cloth, and warm with blanket, and give warm IV fluid. Suspected opioid overdose: you can use naloxone, and make sure you have to repeat the dose because the underlying medication can work for longer time, so redosing is important. Patient with convulsion, if it is hypoglycemia, you give glucose, and also for convulsion you give benzodiazepine. For pregnant lady with hypertension and convulsion, consider eclampsia and give magnesium. And after that, for repeated convulsion, you can give phenytoin or Keppra. If we suspect poisoning after we stabilize ABCDE, we need to give antidote or antivenom, and assess if we can able to manage in our facility or to transfer. Patient with pesticide poisoning, these patients are subjected to excessive secretion. First, you do decontamination, monitor airway, and you need to do suction. And you might need to arrange for advanced airway management. Snake bite, we treat the wound and give antivenom plus the general resuscitation. Patient with rabies, there is no specific treatment here. It's mainly about supportive care. Agitated and violent patient, make sure you know the exit, and also you have to look if there is any weapon or unsafe object. Try to remove them if possible, and always call for help. Protect the patient from harming himself and harming others. And as I mentioned, you call for help. Speak in calm, soft, non-threatening tone. Explain what is happening. Do not confront or judge. Sometimes this could be related to hypoglycemia, so you might need to check glucose and treat accordingly. And sometime you might need to use medication like benzodiazepine or haloperidol. And then you look for organic causes or other anatomical causes. Patient with trauma and altered mental state, assess with GCS, immobilize the spine, and check for increased intracranial pressure. Take home in patient with altered mental status, start with ABCDE, fix any life-threatening condition before you move on. Then you take sample history and do detailed secondary examination. The goal of secondary survey is to figure out any situation can explain the current illness. Always consider hypoxia, hypoperfusion, and hypoglycemia, and don't forget seizure. Do not overlook systemic causes related to heart, lung, liver, kidney, sepsis, and poisoning. Look for intracranial process related to CNS infection, cerebrovascular accident, trauma, or presence of tumor. Pregnant lady, don't forget eclampsia. After that, after you implement a specific treatment, then you need to assess if you are capable to serve the patient in your facility or you have to transfer.